Interesting. I know James since 2008, I think. So I think that's when we first met, not about 15 years ago. It's been a pleasure to be working with James after so many years. Now that I'm back at Health Innovation Manchester. So good afternoon. My name is Daniel Zamora. I'm the program director for the Health Innovation Accelerator, which is the program that supports this project, alongside with all the genomics projects and all the other advanced diagnostics projects. Right, so I'm delighted to chair this panel. We are going to talk a little bit about how we move from great pilots like this to sustainable implementation and large-scale adoption. So just to set the scene, and I think James touched a little bit on this, ideas are easy, innovation is harder, but sustainable implementation is very hard. So how do we make these solutions that really create value at system level, but don't always align with budgets, with local pressures, with local organizations? How we can close that gap to unlock those benefits for the patients, their families, staff, industry, and really all the ecosystem. So I'm going to start off with asking a question to Rick, but I also invite our other panelists to step in. So Rick, you have undertaken many roles, clinical roles, academic roles, across multiple universities, organizations. You've led many research projects, very experienced in navigating the research infrastructure in the NHS, also at NICE. And you're also an editor at the BMJ Emergency Medicine Journal and contributor to the research. So from your experience, what needs to be done to achieve sustainable implementation when we have this type of scenario?
So I think number one, we need some system-wide leadership on it. So it needs to be, because this is going to benefit the whole system. Kevway showed £1.2 million of savings for the system every year, but that's not equally distributed across all of the organisations. So we need something that's going to work across those silos to incentivise us to achieve that system-wide benefit and the patient benefit. But making that work with you can't just say, NRAS, sub it up. You need to pay for this. There needs to be some form of support and incentivisation to get it across the line. The ambulance trust is really the absolutely critical one. I mean, it's been such a huge amount of work for Phil and all the colleagues at NWAS to get this set up, because it's such a complex intervention. So I think it's important to recognise in Kevway's analysis, we assume that every single ambulance across NWAS, 300 of them, would have an £8,000 device. And that doesn't necessarily need to be the way that you would implement this. It doesn't have to be that we'd ask NWAS to put a £100,000 a year bill, or £100,000 one-off implementation bill, at least. You could deploy this on rapid response vehicles like Phil said, and then it'll be cost saving. But even if it is initially cost saving, there's still going to be that initial outgoing and all of the hard work that it takes to set the service up. And into that, it's going to be compound, I think.
Fantastic. Any thoughts to add on to this, for example, from your experience at NWAS?
Yeah, I think it's like anything, it's working together, isn't it? It's very roasted to you to say, well, we all work together, which we do, but the funding doesn't reflect that. As Rick quite rightly says, it's an expensive process, but the benefits for the patient, which we're all in this role to do, are there, but they're further down that line. So it's how do you make it a level playing field? Because unfortunately, finance does come into it. So it's a bigger question. And if anyone's got the answer, great. How do we level that playing field? It's easy for me to sit here and go, well, I would just charge an FT 110 grand and say, give us that and we'll do that. It doesn't work that way. So I think Rick quite rightly says it's a system change needed.
Absolutely. I hear you. So basically it's about supporting organizations to absorb those costs related, maybe sharing risk, sharing incentives at system level. That's what I'm hearing. Okay, cool. So I'm going to move to question number 2. Now you've got the mic, Phil. If we were to scale this up right across to not just the northwest footprint, but looking at England-wise at least, or maybe the UK, what do we need to do to do this more consistently and quicker?
A lot of joint thinking, a lot of joint working, more work. The RCT that Rick mentioned, I think, is pivotal. First and foremost, this needs to be a safe process. Everybody worries with chest pain around the heart attack, regardless of whether they are or they're not. Very scary time. So to implement something like this would need to provide so much reassurance that what we're doing is right and safe, it's the right way to go. And equally, different areas of the UK operate very differently. London Ambulance, for example, send everything to the heart centre and Mirror looks to the ED when it comes to cardiac presentations. And I know speaking to some of them, they want to flip that round. It's similar to the way we do it. So we're not all operating in the same manner. But again, that would be such a big piece of work to achieve, if it was even possible, which I'm not sure it is. But I think first and foremost, we need to nail this down and make sure it's safe before we start pushing out across to other trusts to say, this is what we need to do, this is the savings.
Anything to add from your perspective, Jidin? I understand you work on the quality space. Is there anything around standards that might need to be considered for a bigger rollout?
Yeah, I mean, it's going to be sort of like a massive project to comply to all the standards. It's quite difficult, not just doing it within the labs, within clinic care testing, with the amount of users that there are. So that is going to be like a massive aspect that does need to be considered with all training, ensuring competencies, reagents, everything has to be considered for accreditation things.
Okay, fantastic.
Just to add logistically as well, and I'll touch on in my presentation, but the logistic requirements purely just for MWATs have been quite large, and that's just for 3 stations.
Yeah.
To roll out across just the sites within MWATs will be huge to take that beyond into other trusts. I mean, we were very fortunate that James did all of our ordering for cartridges, and we had quite clear support from MFT, so they received them. They dealt with the black ice that we mentioned earlier on. So we didn't have all of those burdens to deal with now, but we would have to have them in the future. So again, it just, I don't want to say it's insurmountable, but it's a very large requirement that would be across the whole system.
Okay, fantastic. I'm interested to hear your thoughts, Rick, on that Avid has gone in to do a proper randomized control trial across is it England, is it England, UK? Can you give us any snippets of what's in scope?
Yeah, well, it's not funding yet. It's stage change, and we've got our fingers crossed. But if it comes off, the idea would be to recruit at the northwest. We've got involved, the southwest, ambulance service, Wales, Scotland, West Midlands, and London. Yeah, so there's 6 ambulance services with the majority of the UK population covered by those 6 ambulance trusts. So it would be a big trial, but we need a large number of patients in that trial in order to have with confidence, because we expect any safety events to be very rare, which means that we need a large number of patients to get the confidence that there's no increase in safety events.
Fantastic. So I'm hearing this didn't really happen by accident. It needs to be well thought, well structured, a proper trial that demonstrates safety, that the evaluation is robust before it can be rolled out nationally. So thank you for the comments. I'm going to move us now to start bringing the role of industry in the equation. So we have fellow colleagues from industry in the room. And so they for a good partnership to actually operate, they need to be in the room to have these sort of conversations and scope the design of many things. Now I'm going to ask Gill, if you can answer this question. So I understand your role at Manchester University Foundation Trust, your role involves the oversight of the quality systems, accreditation standards within the clinical biochemistry services, and you are currently lead point of care scientist, so a specialist in point of care.
Specialist. Within 5 months.
Okay. So how can, is there a role for industry? How can they collaborate better whilst ensuring the quality standards and governance requirements are met to involve in these sort of projects?
I think the main thing is communication between chronic care teams, users and the suppliers. They're setting up these devices in their labs and everything, but when it comes to them actually working out in the ED units, on ambulances, they're not always as practical as what the suppliers have been thinking. So if you think back to the ambulances, having to take a fridge just to keep cartridges cool. So, you know, it's that initial engagement with the users with chronic care. To come and say, yes, it's great, that device, everything's simple to use, but the reagents, we need them to be able to stay at room temperature for a lot longer. We need your devices to cope with all kinds of cold weather, hot weather, and the one on ambulances. When you're in a lab, you can kind of acclimatise it a bit better, but house ambulances not. So it's getting that initial engagement with the suppliers, and the suppliers talking to us, sort of ask us what we need. Most suppliers are really good with helping with training. I mean, we're going to be talking like thousands of users. That's not something that a point of care team can do. I mean, my point of care team is absolutely fantastic and they will support as much as possible. But when we're looking on that grand scale, we need that support from all the suppliers in the industry.
It's great, folks, some very practical points there. Anything to feel from your perspective in terms of what they can do to hold back these type of projects?
I think how important industry partners are, it's really important. I mean, we've spent a lot of time in a really close relationship with Siemens when we were running this pilot, and it worked really well. But it also, we were able to feed back challenges of working in a pre-hospital environment, because we are at the 365 days a year at all times of the night, really able to sort everything. So we need that device to work and we need it to be quick, easy, robust, because we're really good at breaking stuff. So having that ability to link in and feedback in a real world environment, I think is invaluable.
Okay, and does it feel transactional, the relationship, or it feels collaborative from your perspective?
Yeah, I mean, there's things I've learned so much doing this pilot around point of care testing. It's not something that I've done before, but linking in with different companies. We spoke to Abbott, we spoke to Gill, Siemens. We went to UCM in Vienna and saw lots of providers there. Just the knowledge they bring to this environment, even though they're not part of it, is completely invaluable.
Okay. Rick, any final thoughts on how they can get more involved in the creation and the rollout of these technologies?
I mean, I think I think we completely agree it's a partnership, really important partners. I mean, I'm wondering, from a lab perspective, we've clearly heard from you, Phil, that, this is a massive undertaking to get the QC and the calibration done. And I'm wondering, we got fantastic support from Siemens during this project, didn't we? We were very lucky that they supported us very well with training and things like that. I've got a question for Jill, guys, because I don't know the answer to this. But I think Jill will. How do you think how would you do it? Because would you involve our industry partners have been fantastic, helping with training, for example, going out to the ambulance stations and helping with training of the staff and provision of reagents and things. If it was rolled out, would you see that would be something that a role that they would have in sort of day-to-day operations, or would you have a point of care team dedicated to it?
Oh gosh, I think ideally it would be good to have a point of care team dedicated. You'd need quite a large point of care team, and then they can pick up things like the IQC, the EQA issues. Because at the end of the day, you just want to take your device and run with it and know it's okay. out on the boards, the majority of users do run the IQC on a daily, weekly basis, depending on device, and then we'll need QA samples as well. But there are more staff available to do that. So it's kind of getting the balance and kind of working all together as a team to work out what is going to be the best process.
Yeah, and I think as well, having access to your point of care team, I mean, Jessica, as a point of contact, if I think it's something going wrong with the device throughout the pilot, again, has been invaluable. I said in my presentation before that the QC requirements for the device we use would almost create a role in itself to undertake that level of QC for across the trust and not one person. But even just to have someone like Jessica to bounce ideas off and this isn't working and that's wrong, or I know I mentioned before when we were talking that one of the QC around 8 devices failed, and I was like, oh my God, 15 devices have just failed. What do I do? And I spoke to Jessica and we brought it in, and in return it was a bad batch of QC. And we retested them all and they're all fine, and we did pressure testing. I never knew what pressure testing was until I spoke to Jessica and the Florida team.
Yeah, I mean, that's something that the point of care team do on a regular basis. They will do the troubleshooting. We get calls every day from wards saying, QC's failed, what can we do? And they will look into that. So they've got a vast amount of knowledge on all these kind of things. And they'll work with the companies as well. But yeah, issues like lot failures and things do come up on occasion, but you don't know about it until you've got that lot and you're trying to get the QC clean of it down. So it's definitely working in a big collaborative deal.
And again, points to the scale of that. So to push this out, like I mentioned, across the UK, that would have to be all point of care teams.
Yeah.
Even if that is just the one person, all point of care teams would have to be involved.
Yeah.
So again, it just comments to the size of the undertaking.
Yeah, 'cause some hospitals have larger point of care teams, others there's only like 1 or 2 people actually dealing with the point of care.
Fantastic. So what I'm hearing is bring them early, involve them in the conversations, letting them know what all the things that we have to do for this device to be used in the real world, and not just treating the industry as a supplier, but more like a partner. As they will come with ideas, they come with solutions, sometimes with the capability and capacity to solve any issues that encounter along the road. Right, I think we will have time for a couple of questions before I hand over to Rick for a close. So would anyone in the room want to ask any question, please? And if you can please state your name and role and who you are addressing the question to.
Sure. Thank you so much. My name is Isam. I work for Abbott Point of Care as Medical Director, Europe, Middle East and Africa. And with the collaboration, I've never been more excited about that revolutionary change of the chest pain pathway. One question that keeps falling in my mind, at which stage do we need to partner with the NICE Guidelines Committee so that they can update their clinical guidance document CG95 dated 2016 or the diagnostic guidance DG231. There are lots of documents related to this, and I'm not sure if we're talking about sustainability and scaling up. Maybe there's a step also that needs to be taken into consideration so that everything aligns together.
That's a great question. I think that's for you, Rick.
Yeah, I mean, it's late for me, isn't it? I've got a roll nice. A really good question. I think the timing is right. It only takes one company to notify this and tonight, and then it triggers it. It's not necessarily going to get triggered from within NICE that this needs to be reviewed. It needs to come from outside to say, look, there's loads of new evidence on this, you should look at it. And if that happens too early and NICE then triggers and looks at it and says there's not enough evidence, that's a really bad outcome because then you've got years until they're likely to look at it again. So that evidence is coming, and so I think, and I don't probably won't be very long until we see enough groundswell of evidence, published evidence, for that to be a really compelling case. in the last iteration of high sensitivity troponin guidance, NICE largely relied on diagnostic accuracy studies rather than trials. That might be also the case in emergency departments with point of care tests. You might, I can't anticipate what our committee is going to say, but you might anticipate that would be how they might handle that. But it has to be done in context, in whole blood. That's absolutely clear. So we need not just plasma bank data, we need whole blood data. In ambulances, probably do need the trial data, because that's what everybody's actually saying. You need trial data. So maybe my inclination would be hold on until we've got the trial data before pushing the button on the ambulances, and then we're more likely to get the right verdict when NICE does look at it.
Excellent, thank you.
Very good question, and from experience with other projects that we are supporting, using point-of-care testing onto the genomic side of things, there's different things that NICE would look at, and one is, for example, with full guidance on the usage of, the other one is on an EVA, which is the early value assessment process, which is something that looks interesting, but needs a bit more evidence. So, yeah, staying close to NICE, great question, great advice. So we can
suppose using one more thing, I mean, that would solve the funding issue. Now there's any medtech funding mandates, the diagnostics would be covered within that. Previously, if you get a NICE recommendation for diagnostics, people will know there was no mandate for the NHS to fund that, but that's changing now. So if there was a positive recommendation for this technology, there'd be a funding mandate. That would really help us out in this situation where we want these system-wide benefits.
So diagnostics now would be like drugs.
Exactly.
Yeah, quite.
Yeah, with mandate. Good thought. I'm going to check the list because we don't know the list for the list of mandated products for next year, so we might be able to get a bit of intel on that and what's on that list. Any other question from anyone else? Please.
Pedro, GD, Business Development Director from Battery Services Limited. We supply point of care high sensitive troponin test. We also have some PNP, NT-proBNP on it. We weren't part of this project, didn't know about it. So how do we introduce our product to the next phase of this project?
So that's a really good question. So I think the important thing is to get together with stakeholders who can help you map the path to market and have a decent strategy, because it depends how early the product is. In order to take it onto ambulances, you have to have the end product. So there's a huge amount of work that has to be done for the products before you take it out on the ambulances. It's got to be so robust. But I think engaging the end users is so important, because
Who are the end users?
people like Phil. I mean, there's no one more expert than Phil.
Just take Phil out for me.
If you want to know what's going to work on an ambulance and what's not going to work on an ambulance, but no one's more experienced than Phil, I'd say.
So, very, very simply, for your basics, I would say quick, easy to use, and hard to break, because paramedics got to break and stuff. But yeah, we want accuracy, but equally we don't want to spend an extended amount of time on C, and if you make it too difficult for us to use, it just won't be used. So yeah, ease of use, accurate and fast.
I think we've got another question here at the front, and was there a hand or no?
Yeah, just to me.
Yes, please, Jeremy.
Okay, Jeremy Klein. I'm the monitoring officer for this project, working for Innovate UK, and I've got an observation before I ask my question. And the observation is, so I've had a meeting with the Advanced Diagnostics Accelerator every 3 months over the last 3 years, and I've heard we've had about 5 minutes for this project in each meeting. The rest of the meeting covered the other 8 or 9 projects. And I have to say, this is a brilliant project, but actually all the other projects are very, very impressive as well. So back to Ben's opening remarks, the Advanced Diagnostics Accelerator has been an amazing success, really transformatory across multiple areas of health and diagnostics. So congratulations to the team. My question is that if we look at the trends, it seems to me that the ambulance, which historically has been a thing to convey people from a point of, or from their home or an accident to hospital, becomes actually a site of diagnostics foremost, or at least at first. If that's a logical conclusion of doing this, you do as much testing as you can as early on as possible. So I wonder whether one should be thinking of sort of reframing the concept of an ambulance to an ambulance and early diagnostics vehicle or something like that, to reset expectations to both for your own staff and also patients, and particularly importantly for the funders to recognise that funding put into ambulances is actually worthwhile.
So, yeah, I mean, we did the ambulance service. It used to be, I'm going back a while now, where you pick you up, to take to hospital. There was very little in between. Now, my substantive role I'm going back to is based in urgent care. So it's about keeping patients out of hospital, which is where a lot of points of care testing would probably sit quite well. So I think the presumption is that of that, I'll ring an ambulance, they'll sort me out, they'll take me to hospital. And maybe you're right, maybe we do need to do some more work around the other routes that are available within MWATs. With regards to sort of point of care testing and where it is, I'm a really big advocate for it. Obviously, we're leading this project, but I'm aware of the tests that are available out there. So we talked about the advertised that before, and the alinity and the tests that it can do. I'm very cautious of paramedics and doctors. We serve a purpose in that we're working at pre-hospital setting. Primarily, our role is to stabilise and take to a doctor. I wouldn't want to say force, but we've moved into an area where we sort of sit on the fence of, we're somewhere near a doctor, but we're not quite a doctor, and the emergency side of it. So I'm cautious about how much point of care we take on, because if I go and see a patient, I see an 80-year-old patient, and I do a liver function test because the kit is available for me to do it. But I've gone because she's fallen on her knee, and I go, well, your liver functions now raised, I'm going to take you to hospital for that, because I don't understand the wider approach to it, because I'm not a doctor and I'm not a point of care specialist. So while I think there is a place for point of care, I think we really need to be very cautious about taking the step into that field. Reporting, although chest pain is scary, we've made it quite a simple process in that with the TMAP score and even the heart score and the other things that are out there. It's quite simple in that troponin is only related to your heart. When you get into the realms of, we mentioned before, I was talking to the ladies on the other side around chronic kidney failure can raise your troponin level. What do you do if someone's CKD stage 4? Well, we can't differentiate that, and we shouldn't be doing it really, because that can lead to differentiation to care, and that's how you leave patients at home, and that's how they become worse, and that's how they can pass away. So that's the risk with it. So I think any point of care development, it needs to be evidence-based, but I think it needs to be guided by a pathway, rather than just a paramedic going, well, it's this, so I'm going to do this. We have some very clever people, but at the same time, go back to the fact that we are doctors.
It's a great talk. Any additional points?
I think those are brilliant points, and it's a really brilliant question as well. In some areas of the country, there's community emergency medicine services. London and Scotland hasn't they? And I think a couple of others have been developing them. They have doctors on ambulance vehicles who go out to patients for different things, for things that they might not need to convey the patient to hospital for. So this is another that could potentially be added to the list, but trusts that have got that kind of community emergency medicine service, and you could see it developing in that way, couldn't you? But actually, it's maybe it's taking the clinicians out of the hospital and going to the patients. It's just like the voting, you've got to think about the pathway. It's not just a test, is it? Like you say, you've got to think about the whole pathway, and that includes the training for the people who are delivering the care. But conceivably, you could imagine a vehicle that's really well equipped with lots of diagnostics, point-of-care ultrasound, and you just take the clinician out of the hospital who's already doing those things, but they go to the scene instead.
Yeah. We do have, so I can't talk about accent to everybody, and we have UCR teams. One of the advanced practitioners used to be on my team and he moved over to the community response team or the urgent care team. They'll go out and see patients and then they'll run bloods and send them into the hospitals, or they'll have prescribing rates. So they can provide a higher level of care than an urgent care paramedic. And they have that advanced knowledge and that high level of education because they're masters trained. We have masters trained paramedics. We have some really clever people. But I go back to we're not at that level. And we don't want to replace roles, but we want to we don't want to just stay in this stagnant. We want to see what the options are out there. What can we do within our remit in the pre-hospital setting to keep patients out of hospital and to help ease the burden on the units. Yeah.
Okay, so as we start on the event to close, I want for you to start thinking about one thing that you would like the audience to leave with. And you go last week, could you do the final closure words? But I just want to thank, first of all, the panelists for such insightful contributions. All the effort behind making this project a reality is incredible. It's humbling to see how everything's actually worked and led to today. I do want to do a bit of promotion as well. So this is one of 3 events that we are going to have during the next few weeks. So do join us we have another event on the 11th of March that's going to focus on the community diagnostics programs that we did. We're going to focus on heart failure, liver disease and lung cancer. And that's in this building. And then we have another one on the 18th in the Royal Northern College of Music, focused on point-of-care testing. So we're going to bring some of the point-of-care testing that we used today, but we'll also have genomics, lipids testing, and remote spirometry. So you're invited. The details are on our website, on the events section on our website. Right, so before Dr. Close, final thoughts from you, Phil?
Just that it's great to see so many people coming together and showing the interest in this subject. Like I said, it was new to me when I started this process. So, and it's amazed me at what is out there and what is available. But it has to solve a problem. It can't just be because we want to do it.
Thank you. Gillian?
So I'm new to this post, so it's been great to see everybody and to get the engagement with Rick and with the ambulance team and just try and improve things for patients, really.
Yeah, I mean, I learned so much during this project. I think we underestimated, when James sat me and him sat down and worked out what we do during the project, we completely underestimated how much work was involved in setting this up. And actually, now looking back at how much work was involved in it, I'm just amazed that the team delivered it because it's almost delivered impossible. But the thing is, it's not impossible. The team's shown that you can do it to set precedent. It is feasible to do this. There's huge benefits to be had. There's cost savings, patient benefits. And it's not just component testing either, because if we can get this in, you could have, and it benefits patients, and you could actually roll out so many more point-of-care tests, pre-hospital as well. So it really could be a new era. And, when there's sort of pressure on ambulance services and emergency departments, we've got to try and continually do things to ease that. And this is a thing that we've clearly shown, I think, that has great potential to do exactly that. So hopefully this project will lead on to, one visible way, lead on to that implementation, but there's a lot of work still to do. Shall I move on and just close the event? So I want to say thanks to everybody for joining us today. Really appreciate your engagement. I hope that it's been helpful for you. I hope that for industry colleagues, it helps you to understand the evidence, the requirements, what we might need to do in order to get to sustainable implementation. Clinical colleagues, hope it gives you some pointers and hope it moves us further towards getting this into routine practice. want to say a few thanks as well. And James listed a huge number of stakeholders. I'm very grateful to James himself. He hasn't been thanked yet, but it's been, I've worked with you for a long time as well. And I thought you were cheeky at first, to be honest. And you are actually both of those things. It's also really funny and really good at what you do. So it's been an absolute pleasure to work with you. And Rhiannon and Bill, you've literally done all the heavy lifting on this project. Your expertise is absolutely incredible. I've never known a statistician in English literature to degree. But it's really helped with writing the project. It's very eloquently written and very robust analytically too, so it's fantastic. And I don't know how you achieved what you did getting these really tested into cars. It's been fantastic. I see the NWAS innovation team here too, and I want a big shout out to you because you made this all possible. And thanks to Health Innovation Manchester for the incredible support as well. Thank you.